Hi everyone, I'm Dr. Roman and I am a board certified hematologist oncologist, and today we're going to go over pancreatic cysts, especially IPMNs. Now this is going to be a very comprehensive video. I'm going to be throwing a lot of information at you, so please do not feel overwhelmed. If you need to, pause, go back, watch it again. We're going to go over anatomy, we're going to go over diagnosis, imaging studies, treatment, follow-up. I mean, things that I believe you should be doing if you have an IPMN or if you have a family member that has an IPMN. So again, I got to go over all of this in detail so you can really understand what is an IPMN and what I think you should do if you have an IPMN. Now, the reason I'm doing this video is I'm a practicing physician. So in this video, you're not going to see all the fancy editing. You're not going to get all the mumbo jumbo. I'm gonna dive right into it. I am seeing these patients more and more often, and I even have a few young patients. Okay, so I felt that there's an unmet need for a really good video to educate patients as far as what an IPMN is, because let's face it, pancreatic cancer is a scary thing. It's a scary diagnosis, and when you tell a patient that they have a risk factor for pancreatic cancer, it really brings up a lot of stress. So that's the main reason I decided to make this video, and hopefully I'm able to help you out. Towards the end of the video, okay, once we tie everything up, I promise you, you may feel lost or overwhelmed at the beginning or in the middle stages of this video, but towards the end, I'll do my best to really tie it all in, and I believe that that's when it's gonna really sink in for you, okay? And at the end, I have a little bonus, and I'm going to give you my advice as a doctor who sees patients with this. I'm going to give you my advice or my recommendations as to what I would do if I had an IPMN. Now, last but not least, a little disclaimer here. Remember, I am not your physician. I do not know the details of your specific case. So this video is for educational purposes only. I'm not recommending any type of treatment. I'm not telling you what you need to do. That's what your doctor is for, so watch at your own risk. With that being said, let's get started. All right, now let's get into the anatomy and the function of the pancreas. This is an organ that sits pretty deep in your abdomen, okay? It's surgically, it's very difficult to get to. Surgeons have told me that when you're in the operating room and you're touching the pancreas, it kind of feels like if you were touching raw salmon. A raw piece of salmon. The thing with the pancreas is that it's in a difficult place to get to surgically, and also it produces some toxic stuff. These juices, these pancreatic juices as they call them, they're responsible for breaking down protein, fats, your lipids, carbohydrates. And the problem is that if you do a biopsy or if you resect a piece of pancreas and there's a leakage of this fluid, it can literally start digesting whatever it comes into contact with, so surrounding organs, etc. And that's what makes surgery, not only because it's in a difficult place to get to, but if you have pancreatic leakage of these pancreatic juices, it can really wreak havoc in your body. So that's the main issue with surgery or biopsying the pancreas. Now, the pancreas, besides producing these pancreatic juices that have to do with digestion, they also produce insulin, which will help lower blood sugar, or glucagon, which will help raise blood sugar. And these are dumped directly into your bloodstream. So not really pertinent to anything we have to talk about here, but I just wanted you to know that the pancreas has a lot of important functions. It also produces other stuff, but again, it's not pertinent to this talk. Now, the pancreas is divided into the head, the neck, the body, and the tail. Just know that the small intestine is adhered to the head of the pancreas, and over at the tail end, you have your spleen over here. You also have major blood vessels that are in proximity to the pancreas. As far as an IPMN is concerned, you need to know this basic anatomy of the pancreas. Here in the middle, you have your main pancreatic duct, okay? And then you have these little smaller branch ducts all throughout your pancreas. So as your pancreas produces these pancreatic juices, okay, it all goes into these small ducts that then gets thrown into the main pancreatic duct and then expelled out into your small intestine, okay? So when I talk about a main duct IPMN, I'm talking about an IPMN that formed right here in your main duct. When I talk about the diameter of your main pancreatic duct, I'm talking about the diameter of this duct from here to here, okay? From here to here, for example. When we talk about a branch duct IPMN, we're talking about an IPMN in one of these branch ducts. And it could be anywhere within the pancreas, okay? So once again, you have the head over here, the neck over here, the body, and then the tail, most distal, close to your spleen. All right, now we're going to go over a concept that I really believe you need to know in order to put these things, to help you put all this together, okay? And that's the concept of dysplasia. So when you have surgery of the pancreas, or they take a biopsy of the pancreas, they're going to look at that tissue under the microscope, and the pathologist will be able to tell us if that tissue is normal pancreatic tissue or abnormal tissue. And the abnormal part can really vary, because the abnormality can be minimal or the abnormality can be very abnormal. So let's say here you have normal tissue. They're looking at it under the microscope, and the pathologist says, you know what? That looks completely normal. Okay, great. Now the next step is what they call low-grade dysplasia. You look at it under the microscope and it's not completely normal. You're starting to see some abnormal tissue, but not much. So it's not that bad. Now, if that abnormal tissue continues to become a little more abnormal, then it's intermediate grade dysplasia. And if it becomes a little uglier, okay, more abnormal, then it becomes high grade dysplasia. Now, high grade dysplasia, when it comes to pancreatic tissue, is also known as carcinoma in situ. All right? It's already, it looks like cancer cells, but it just hasn't invaded yet. Then it'll become an invasive cancer, and then from there, it can metastasize. This right here is already bad. You want to try to get it as closer this way as possible, okay? So a little recap. Remember, this is, if you have a biopsy, we look at it under the microscope, typically a pathologist, and they'll tell you it's either normal tissue or it's already somewhat abnormal, but very minimal. That's low-grade dysplasia. It's a little more abnormal. It's not minimal anymore. It's intermediate, so it's intermediate grade dysplasia. Dysplasia meaning abnormal tissue. High-grade dysplasia, which is already knocking on the door of an invasive cancer, and you really want to try, as far as an IPMN is concerned, you really want to try to detect it in these earlier stages, okay? Because once it becomes invasive, then the prognosis of the patient is much, much worse. That's already a pancreatic cancer. We want to try to prevent it from getting to that level, all right? Low-grade dysplasia is excellent. The thing is, a lot of people with low-grade dysplasia never develop into the higher grade dysplasia. So if a patient goes to surgery, and after, once that piece of pancreas is taken out and all they find is low-grade dysplasia, then you can argue the point that maybe that patient did not require surgery to begin with. But as you'll see in the next portion of the video, it's easier said than done. All right, now that we got that out of the way, now we can get into the fun stuff, okay? And that's talking about actual pancreatic cysts. So the first thing I want to tell you is that there are many different types of pancreatic cysts. And I want to tell you now, I guarantee you that some of you watching this video may think you have an IPMN, but you may not have an IPMN. You might have another type of pancreatic cyst. And I'm going to try to go over a few of them just so that you keep this in mind. But I can tell you, again, by the time you're done with this video, you'll know what I mean, but it can be quite a challenge to diagnose these pancreatic cysts. Now, the first cyst that I want to go over is a simple cyst. They also call it a retention cyst. The simple cysts that you tend to get, for example, in the kidneys and the liver, the kidneys very common to have cysts. The ovaries in women also a common site to have cysts. The majority of those cysts, especially kidney cysts, for example, are benign. Now, to have a benign, simple cyst of the pancreas is very, very rare. It's possible, but very rare. So I just want you to know that there is such a thing as a simple cyst. Now, there's another entity that's called a pseudocyst. This is typically seen in patients who are drinkers or had gallstones or had some sort of an insult to the pancreas. They had pancreatitis. It's seen in acute pancreatitis, but it's more often seen in chronic pancreatitis. So if you're a patient that has had, you've been told that you have chronic pancreatitis, and all of a sudden you have a cyst that's communicating with the main pancreatic duct, that's why you need to know the anatomy that we went over. Now you know what the main pancreatic duct is, that you see that this cyst communicates with the main pancreatic duct, you could have a pseudocyst. And the thing is, these cysts tend to get better with time. They tend to shrink and might even disappear, although sometimes they linger. I'm using my little sheets here so that I don't get lost, because there's so much information I want to give you that I'm kind of using my little cheat sheet, if you will. And like I said, they do communicate with the pancreatic duct. And the important thing here is that some patients will tell you, oh, my cyst got better. Yeah, they thought they had an IPMN, but what they really had was a pseudocyst. You always have to keep that in mind. There's many different types of cysts. Now, there's another cyst that's called a serous cystadenoma. This has a particular finding. They're almost always benign. They're almost always found in the body and the tail, and they tend to have, they can appear in different ways, but they tend to be multicystic. Okay, when you look at it in an MRI scan or a CAT scan or an endoscopic ultrasound, which we're going to go over all of these, they tend to have multiple cysts. They call them, it looks like if they're grapes clustering together. They also call it as they're honeycombing, as a honeycomb lesion. You really have to think of the possibility of a serous cystadenoma. You leave these alone, 99.999% of the times they don't turn into anything. So, just wanted you to keep that in mind. Now, if these are causing symptoms, if you have a serous cystadenoma and it's a very large one or it's causing symptoms, then sometimes surgery is the way to go. There's also another type of cyst. It's usually a mass, but it can also be cystic, and that's what we call neuroendocrine tumors. Now, these usually you have to resect because a lot of times they cause symptoms, they can grow. That's beyond the scope of this talk, but I just want you to know there's another entity. I actually see this quite a bit. They're called neuroendocrine tumors. Okay, not an IPMN. That's something else you may have. Now, let's focus on mucinous cysts. So you have one that's called a mucinous cystic neoplasm, typically in middle-aged women. It's almost always in the body of the tail. These tend to grow fairly large, and a large number of these can become malignant or have cancer at the time of diagnosis. So if you have one of these, surgery is the way to go. The other type of mucinous cysts are the IPMNs, which we're going to concentrate on for the remainder of this video. So from now on, everything we go over is IPMNs, okay? So again, I'm looking down to make sure I don't miss anything. So we're going to try to go over all the basics on an IPMN. This is a little boring, but I want you to know, just know that if you go to surgery or if you biopsy the pancreas and you have an IPMN, it can have several different types of tissue, not just grades of dysplasia. Remember, we can have the low-grade dysplasia, intermediate, high-grade. It can be a cancer, God forbid. But there's the actual tissue of origin can be divided into a gastric type IPMN, an intestinal type IPMN, a pancreatobiliary IPMN, or an oncocytic IPMN. Now, these are the 4 different tissue types that you can have. The importance is that if you have a pancreatobiliary, those tend to be worse. Now, this really doesn't help us because the only way to know this would be with a biopsy. And most of us don't have a biopsy. Or if you go to surgery and they took this portion out, a piece of your pancreas out, then they'll most likely be able to tell you which type of an IPMN you have. But if you're simply following an IPMN with imaging or a CAT scan, etc., This really does not help you because you will not know which one you have. You need tissue, you need a biopsy, you need a surgical specimen, a piece of your pancreas to be able to know which one you have. And the worst tends to be the pancreatobiliary type IPMN. Now let's go over how we divide, or the different types of IPMN, radiologically or anatomically. So the first type, there's three main types: the main duct IPMN, the branch duct IPMN, or the mixed. So remember when we went over anatomy, again, the importance of knowing the anatomy of the pancreas. If you have a branch, let's actually talk about a main duct IPMN. So main duct IPMN, okay? It's about 25% of IPMNs. The thing is, about 40 to 60% of the times, these can have cancer or they can become cancer. So that's why most main duct IPMNs will go to surgery, okay? The mixed type has both in the main duct and the branch duct. And again, I just told you that 40 to 60% of the times, main duct can have cancer. So that's why it's important to distinguish a main duct, a mixed versus a branch duct. So those tend to go to surgery as well, and we will get into much more detail later on. The last one, which is much more controversial, is a branch duct IPMN. Remember those little branches that they release the little gas, the pancreatic juices into the main pancreatic duct. If you have a branch duct IPMN, the majority of those do not become cancer. So that's an important thing to know, because if you're going to decide on surgery or no surgery, you really have to think twice before sending a branch duct to surgery. Now, the diagnosis. We're going to cover a lot of information. Now we're going to talk about CAT scans, ultrasounds, MRI scans, what I think, and just some little basic concepts that I think you need to know. So, for the most part, when I see these patients, the grand majority of patients, the IPMN or this pancreatic cyst was found incidentally, okay? Patient went in, for example, they had a kidney stone. So they had a scan and yep, they found a kidney stone, and guess what? They found a little surprise in the pancreas. Or they went in for another test and an MRI of the spine or whatever the case may be, and they'll tell you, oh, we found a little something in your pancreas. I can't tell you how many times I hear it's a recurring theme, okay? Unfortunately, you go in thinking one thing, and then all of a sudden you're surprised with a diagnosis of an IPMN in your pancreas, and then you're freaking out. IPM, what? Most people don't even know what this is, and then most primary cares don't even know what this is, and then this just opens up a whole can of worms. So the first thing I want to go over is an ultrasound, all right? So this is the same test that you have when you're pregnant, okay? The good news is it does not give off radiation, so you're not exposed to radiation. The problem is the simple ultrasound, the transabdominal ultrasound, okay? They put that little jelly on your abdomen. It's not a very reliable test for the pancreas. So yes, it does not give off radiation, but it's not a very good test. Now, I have seen some very thin patients, okay, very skinny, and they go for an ultrasound, transabdominal ultrasound, and they have detected something in the pancreas. So, but if you're a little overweight, or for the most part, most of us, you will not be able to thoroughly evaluate the pancreas, because remember, the pancreas is deep within your abdomen. So you have intestine on top, you have your, just fatty tissue, muscle layer. So by the time that ultrasound is reaching your pancreas, you really cannot visualize your pancreas. So not really a test I recommend, okay? The transabdominal ultrasound. Now let's talk about a CAT scan. The CAT scan, or the CT scan, okay, is a test that can be either plain or with IV and oral contrast. The IV contrast is the important one. Now, the important thing about a CAT scan is that it does give off a little bit of radiation. So every time you have a CAT scan, you are being exposed to a little bit of radiation. And one CAT scan, chances are, isn't going to do anything. But if you have 2, 3, 4, 5 CAT scans, guess what? Now it's not a little bit of radiation. And next thing you know, you're getting another type of cancer because you're being exposed to all this radiation. So I am thoroughly against, unless you really need to, I'm against having repetitive CAT scans, because I don't want to cause more harm than good. Just something for you to keep in mind. I'm not telling you not to get a CAT scan, but it's just something you need to keep in mind. Now, a CAT scan of the pancreas without contrast, in my opinion, is not a good test. And I'll tell you why. Again, this is just my opinion. I have seen a few patients whom I know have an IPMN because we've seen it on various tests, but yet they have, let's say for kidney stones, they have a CAT scan without contrast and they do not see the IPMN. So just something for you to keep in mind. If you're going to have a CAT scan, in my opinion, you need to do so with contrast. Now, if the IPMN is very large, there's a good chance that the CT scan without contrast will detect it. But in my opinion, if you're going to have a CAT scan, make sure it's with contrast. Remember that the contrast with a CAT scan can ruin your kidneys, especially if you have pre-existing kidney issues or if you're dehydrated. Make sure you're not taking metformin, the diabetes medication, just throwing little things at you. And when you have a CAT scan with contrast, try to drink a lot of water so your body can eliminate this, okay? It's a very good test. It just does have some drawbacks. Now let's go over an MRI scan. For me, the MRI scan is the best test for the pancreas. One of the best. Let me not say the best. It's one of the best non-invasive tests for the pancreas. The MRI scan does not give off radiation. So it doesn't matter how many MRI scans you have, you're not being exposed to radiation. So that's a plus. Also know that when you have an MRI scan, it can be with and without contrast. Now, I have seen that MRIs, even without contrast, are better than CAT scans without contrast, okay? So, but if you do have an MRI with contrast, it is a superior test. You can look at the cyst, you can see if the cyst wall is if it's illuminating, if you will, if it's having uptake on the actual cyst, you can see nodules within the cyst better. An MRI scan with contrast is a better test. Just know that if you have kidney issues, you should not have an MRI scan because the dye that they use is called gadolinium. And gadolinium is a metal. And if your kidneys are bad, that's the way that the body eliminates the majority of the gadolinium. And just like the CT scan contrast, the MRI contrast called gadolinium can also cause bad things in your body if your body cannot get rid of it. I do want to take the time to tell you that gadolinium is a metal. So we're injecting this stuff in your body. Your kidneys eliminate the majority of it, but your kidneys do not eliminate 100% of this. And the reason I mention this is that if you're a young patient and you are having an MRI scan every 1 to 2 years, I've seen patients who, not only for an IPMN, but for many reasons, they'll have a scan and then a year later they have another one with contrast, and then a year later they have another one with contrast. And by the time that they're 60, 70, maybe they've had 10, 15, 20, MRI scans with gadolinium. And it makes me a little nervous just knowing that your body is accumulating all this metal. Just something for you to keep in mind. Now, it is a very good test, especially with contrast. Now, there's another type of MRI. It's called an MRCP. It stands for magnetic resonance cholangiopancreatography. It does not use contrast, and it's a very good test. It creates images of your pancreas. It creates images of your biliary tree. Very good test. It does not require contrast. Now, if you combine the MRCP with an MRI with contrast, then it's a much superior test. The problem is that it's a very long test. And we all know that the CAT scan, which is a very simple, fast test, the MRI is not. You have to go in, and it's a long test. You have to cover your ears. It's a very noisy test. They tell you to hold your breath because, you don't want to be breathing and distort the image while you're breathing. Remember, when you're breathing, your intestines, everything is moving. So they ask you to hold your breath so that your pancreas sits still and you try to get very good pictures of your pancreas. Not to mention, with both the CAT scan and the MRI, that hot flash feeling that you get when you're injected with all these things. So just something to keep in mind. But an MRCP is a very good test. It does not require contrast. And again, it's an MRI type test, so there's no radiation by having an MRCP. What about a PET scan? Very good test, but not for an IPMN. A PET scan is used to find cancer. And if your IPMN is lighting up on a PET scan, chances are it is cancer. So it's not a very good test to follow an IPMN. And also, so the majority of my patients with an IPMN have a completely negative PET scan. Not that I ordered the PET scan, but if they had a PET scan for whatever other reason, their PET scan is usually negative. Also, the PET scan gives off quite a bit of radiation. The PET scan is using both, it's a nuclear dye which contains radiation, as well as most PET scans is a combination of a PET CT scan. So you're getting radiation from the CAT scanner and also from the stuff they are giving you in the vein. Now we're going to get into the gold standard, in my opinion, which is the endoscopic ultrasound. You have an endoscopy, okay? The gastroenterologist puts the tube down your throat, and then you have an ultrasound via an endoscopy. That's a very good test. It's actually, in my opinion, the best test to look at the pancreas. You really get detailed information on the pancreas. You can look at the cysts. You can look at the main pancreatic duct. You can look at all these things. The problem is it's invasive. You have to go in. They have to put you under, usually conscious sedation. So it's a little more of a hassle, much more of a hassle than just going in and having an MRI scan or a CT scan. But it's a very good test, and it does not expose you to radiation. So there is no radiation involved with an endoscopic ultrasound. Very important test. The other thing about the endoscopic ultrasound is, think about it. You're going in, the pancreas is touching the stomach. So they go in with this camera, and then they release the probe, the ultrasound probe, which is right up against the gastric wall, and your pancreas is right behind it. So they can literally go throughout the whole area of the pancreas, visualizing the pancreas. And if you see something, they can try to get an aspirate or a biopsy. So with the other methods, it's just a picture. With the endoscopic ultrasound, you're getting a picture, a very good picture, and you can actually intervene and obtain either a biopsy or put a needle and try to suck out a little bit of the juice within the IPMN or the cyst, whatever cyst it is that you are evaluating. So very good test. The last test is an ERCP. ERCP, not done very routinely. It does give off radiation. So for that, you need to have an endoscopy. They put a probe canalizing your main pancreatic duct, and then they use fluoroscopy, which is another type of imaging test, and that does give off some radiation. The risk with that is pancreatitis. Okay, it's been associated with pancreatitis. That's more an older test. It does have some indications, but an ERCP is not something that's thoroughly used. So as a recap, remember, you have your ultrasound, not endoscopic ultrasound, just your transabdominal ultrasound, not very good. CAT scan, especially with contrast, pretty good test, but gives you radiation a little bit. MRI scan, very good test, no radiation. With IV contrast, gadolinium is better. But if you have an MRCP, it's still a very good test. Not as detailed as if you have contrast, but it's still a very good test. Your endoscopic ultrasound, very good test. In my opinion, the best one out of the imaging type test. But it is invasive, and you can get biopsies and aspirates. Remember that with any biopsy of the pancreas, you run the risk of pancreatitis because of the leakage of the fluid that we already mentioned. But it is, in my opinion, the best test. And your ERCP, not really used nowadays, although it does have some indications. So now we are going to go into how do you diagnose these things? Well, you have an imaging test, any one of the ones that I already mentioned, and it's going to tell you there's a pancreatic cyst. Now the question is it an IPMN? Well, it'll typically have its characteristic appearance, and usually the radiologist will tell you, you know what, it looks like a cyst in the main duct, so it's a main duct IPMN, or it looks like a branch duct IPMN. And a lot of times they'll tell you there is communication seen with the main pancreatic duct. And that if you do see a cyst that looks like an IPMN, and there is communication with the main pancreatic duct, then it is most likely an IPMN. Although I can tell you, you cannot say 100% that it is an IPMN. All right, always keep that in mind. It's most likely an IPMN. But it's not going to really confirm an IPMN. And I can tell you that this brings a lot of stress because I see patients come in and they have a cyst and it'll tell you no communication seen. Okay, doesn't need to. Okay, a lot of times you simply won't see it. It's just a picture. Maybe the picture didn't detect the communication, or it'll tell you there is communication. So that would put an IPMN a little higher on the list. but it does not necessarily confirm that it's an IPMN. I'm trying to use very specific terminology here, okay? So it's when I told you before, a little easier said than done. Diagnosing these things can be quite a challenge, not to mention all the stress that it brings the patient. So as I already told you, we can do an aspirate or a biopsy. Biopsies are seldom done because of the risk of pancreatitis. So if you have an endoscopic ultrasound, a lot of times the GI doc will put a little needle and will take out a little bit of fluid. Okay, and that fluid will be sent out for analysis. Okay, the pathologist will analyze it in several different ways, and they'll look for several different things, which we're going to go over now. So everything we go over now is basically an analysis of the fluid. Okay, so you had an endoscopic ultrasound, they took out a few cc's of this, a clear liquid is usually what it appears like, and they send it off. So the first thing we're going to look at or discuss is cytology. Okay, cytology. They go in there with a needle, they take out a little bit of this fluid, they spin it, and then the pathologist looks at the sediment under the microscope. I can tell you the grand majority of the times they don't see anything. It's not a very good test. Now, if you find circulating cancer cells, that's not a good thing. Or if you find abnormal looking cells, remember, what does that remind you of? Abnormal looking cells, dysplasia. That's what you tend to see. An IPMN is a dysplastic lesion. Now, you can see low-grade dysplasia, high-grade dysplasia. Sometimes in cytology, they can just tell you atypical cells were seen. Okay, so if you see this, that merits further investigation. But I can tell you that for the most part, most patients that have cytology, it'll come back as normal. And people say, wow, hallelujah, amen, it's normal. It doesn't necessarily mean that you're off the hook here. You may still have an IPMN. They just did not see anything on that specimen. And I can tell you that the majority of the times, the specimen comes back normal. So something for you to keep in mind. That's cytology. Now, what about tumor markers? And the first one we're going to talk about, or the main one, is your CEA, stands for carcinoembryonic antigen. Again, we take out that fluid and they can analyze it for your CEA. That's different than your blood CEA, okay? This test, in this case, I'm talking about a CEA level in the fluid that was aspirated during a biopsy or during an aspiration of the cyst. It's pretty accurate, okay? If your CEA level is greater, the magic number they say is 192 nanograms per milliliter, and they say that its accuracy is about 70% plus or minus. So if your CEA is high, usually greater than 192, it usually implies that this is a mucinous lesion. And remember, IPMNs are mucinous lesions. So if your CEA is high and on imaging it looks like an IPMN, then it puts IPMN at a much more likely diagnosis. Now, the CEA level, let's say you have 1,000 versus 200, okay? Of course, if you ask me, I would rather have 200, not 1 or 2,000, because why have a tumor marker higher? Nobody wants that. But from what we know, it does not correlate with malignancy or the need for surgery. So if you have a very high CEA level, it does not necessarily mean that you're going to have higher grade dysplasia, and it does not necessarily mean that you're going to need surgery any sooner. Okay, so right now, the way we use CEA, unless something came out today that I'm not aware of, we only use CEA to tell us, you know what, this is more likely or most likely a mucinous lesion like an IPMN. Now, I also want you to know that the accuracy is in the 70s, as I already mentioned. So even if you have a lower than 192 CEA, it does not guarantee you that this isn't an IPMN. Again, remember I told you, easier said than done in diagnosing these things. Amylase, I really don't use amylase. I don't think it's very useful. So, as far as an IPMN is concerned, why waste? I'd rather use that fluid for other reasons. The other one is a glucose level. So we can check for glucose levels within that fluid. Remember, that's like blood sugar. And the lower the glucose, the higher the chance that this is a mucinous lesion. So the number tends to be 50, okay? But if less than 25 milligrams per deciliter, it puts a mucinous lesion higher on the list. So lower glucose level, higher chance that this is an IPMN. Another one which is becoming more and more important and is being used a little more frequent is molecular testing. And there's two molecular tests that we are using more and more frequently nowadays, although there are others, but these are the two main ones, and that is KRAS, K-R-A-S, and GNAS, G-N-A-S. They're pretty good tests. If you have a KRAS or a GNAS, a molecular mutation found, chances are you have an IPMN. Okay, so let me repeat that. These are molecular tests, not that easy to do, but you take out some of that fluid from the pancreatic cyst, you send it out for analysis, and if you have a KRAS positive molecular test, it's about 95% certain that you have an IPMN. If you have a GNAS, G-N-A-S, positive molecular test found, it's almost 100% that what you have is an IPMN or a mucinous lesion. So food for thought. But just remember, as far as the KRAS is concerned, the sensitivity is about 50%. So about 50% of the times when you do the test, it's going to come back negative. So again, it's not ideal. It simply means that if you have a positive test, chances are that is an IPMN. If you have a negative test, you still have about a 50% chance that it is an IPMN, just the test did not come back positive. Again, remember, I'm going to tell you again and again, easier said than done. Diagnosing these things are not simple. Because I've seen patients that'll come and will have a negative cytology, or they'll have a CEA that's 100, or will have a 100, or they'll have a glucose level that's borderline, or they'll have a negative KRAS, and they tell me, great, I'm off the hook. Not necessarily, so that's why I'm a little more vigilant on these patients, and I still follow their pancreatic cysts. I just don't tell them, you know what, go home, you have nothing to worry about. We always have to keep that in mind. Now we're going to get into the treatment. All right, very complicated topic. Treating these things is not simple. So just know, as already mentioned, the pancreas sits in a difficult place. When you start cutting into the pancreas, you can have leakage of pancreatic juice, and that can cause a lot of issues: fistula, pain, impaired wound healing, infection, etc., etc. So there's different types of surgery, and you need to know this because some surgeries are simpler than others. So in general, there are three main types of surgery. There are others. I just want to try to keep it as simple as possible. The first one is if you go for a distal pancreatectomy. So going back to the anatomy, they will basically cut either at the body or the tail. They'll usually take out the spleen, although they don't always have to, and that's called a distal pancreatectomy. Much easier surgery, and the recovery is night and day compared to some of the other types of surgeries. The other type of surgery, a little more complicated, or significantly more complicated, is a Whipple surgery. And this is usually performed when you have a resection more towards the head of the pancreas. And the issue here is, remember I showed you on the anatomy that the small intestine is all wrapped around the head of the pancreas. So in this case, they will cut out part of your small intestine, part of your biliary tree, the head of your pancreas, and then they'll join the distal part of your pancreas, the body and the tail, to the small intestine. Much bigger surgery, although I can tell you that the surgeons are becoming much better at these surgeries. They're getting much more experience. And the last and the biggest type is a total pancreatectomy. Now, this surgery has quite a bit of morbidity and mortality. It's easier said than done because remember, then you're guaranteed to become a full-blown type 1 diabetic. You also lose glucagon, so you're going to have the low blood sugars, the high blood sugars. It just becomes a mess. And although nowadays they also have these insulin pumps, which are really making things better. But just know that a total pancreatectomy is a whole different ballgame, and you really have to be physically fit to undergo this type of surgery. And there's different ways of getting to the pancreas. Okay, so you can have what they call minimally invasive, which can either be laparoscopic or robotic, two different types of laparoscopic, or two different types of minimally invasive surgery rather, or you can have an open resection. If you can go minimally invasive, either robotic or laparoscopic, that would be my choice. But I would really talk it over with the surgeon, because remember, the last thing you want is complications. You want to make sure the surgeon feels comfortable depending on where your IPMN is, your age, other factors. So it's not just jumping in there and saying, oh, you know what, I want to have a robotic surgery or a laparoscopic surgery, because minimally invasive surgeries, for the most part, take a little bit longer than open surgeries, although the recovery tends to be faster. So with that being said, as far as the treatment is concerned, question number one is, do you have an IPMN? I mean, that's the question. When I get patients with this, my first question is this truly an IPMN? Can we get, based on imaging rather, does it look like an IPMN? Can we obtain an endoscopic ultrasound and obtain fluid? Or, can we send this out for KRAS and GNAS testing? Can we get a CEA level? And then it's kind of a little puzzle. You're putting it together, and I'll say, you know what? I'm almost 99.9% sure this is an IPMN. Well, rather, I have other patients where I have my doubts. I'm asking myself, is this truly an IPMN? Am I really going to send this person for surgery? Am I going to follow this person? And that's where the dilemma begins. So the first question, as I said, is, do you have an IPMN? And the second question is, do you need surgery? Not everybody needs surgery. We're going to get into that now. So for the most part, if you have symptoms of an IPMN, you have jaundice, you have pain, which is significant, then that might be criteria for surgery. The difficult part, and I can tell you because I see these patients, is you may be having pain due to something other than your IPMN. And sometimes it's a little difficult to truly know if your IPMN is what's giving you your symptoms. But I can tell you from experience, unless your IPMN is huge, okay, very large, or it's obstructing the main pancreatic duct, or it's, doing something else, for the most part, patients, your pain is not from your IPMN, for the most part, unless, as I already mentioned, you have a very large one, or you have other things going on. So, I can tell you that most patients I see, they're pretty asymptomatic, or their pain or their tenderness, I can attribute to other things. So let's first talk about a main duct IPMN. So as I told you, it's not as common, but if you have a main duct IPMN, in my opinion, if you're a candidate for surgery, you should probably go to surgery. Okay, if you're young, if you're medically fit, if you're older but you're fit, then honestly, your chance of cancer is 40 to 60%. We're talking about risk of pancreatic cancer, so you don't want to play games here. So I would probably recommend surgery most of the times for those patients. Now, of course, if you're afraid that the patient's not fit, they're older age, they have pre-existing heart conditions, and you're afraid that they may die in surgery, then you really have to think twice. So you have to make that decision. If you have a mix, you have both branch duct and main duct. Again, we're going back to the main duct. We already spoke about that. 40 to 60% cancer risk, although mixed tend to have a little bit lower risk, but still you don't want to play games. If you're medically fit, I usually recommend surgery, and the surgeons that I work with usually agree with that. The branch duct IPMN. Here's where the problems begin. As we already mentioned, the branch duct IPMNs are more common, so these are the bulk of the patients that I am seeing. And the thing is here that a lot of these patients can live a normal life and do not develop cancer. If you have a branch duct, and that's what we're going to go over now, you really have to divide as far as what's the risk that this thing can become cancer, okay? And there are several different guidelines that we use. I'm going to try to just go over just common sense, but the Japanese tend to have their guidelines, Europeans have theirs, the Americans, we have ours. I like to use somewhat of a multi-guideline approach, if you will, because I want to use common sense. Remember, I'm not in a university setting teaching medical students, not seeing patients. No, I'm seeing patients every day. We have to make decisions, okay? And then I try to put all this together, not only the guidelines, but looking at the patient in front of me. How old are they? How strong are they? I go less by age. I go more by how good the patient looks. How strong are they? How many medical problems they have. The less medical problems, the more aggressive I'm going to be. So let's start off with what they call high-risk stigmata, or high-risk features. And those are, if you have a mass in the pancreas, especially in the head of the pancreas, causing jaundice, the yellowness of the eyes or the skin, for me, that's surgery. You should never have a mass in the head of your pancreas. Or if you have sort of a cyst that's big enough to cause jaundice, that makes me worry. The second thing is if your main pancreatic duct is dilated. Remember, we went over the anatomy, the main duct. If it's greater than or equal to 10 millimeters, that's a high risk feature. Okay, that's high risk stigmata. Strongly consider surgery. Or if you have an enhancing component within the cyst. So if you look in the cyst, you typically need contrast to see this, and you see a nodule, okay, that's enhancing, okay, it's lighting up, and it's greater than or equal to 5 millimeters, that's another high risk feature. And if you have a few of these, for example, you have a 5 millimeter enhancing cyst, and you have a main pancreatic duct that's 10, 11 millimeters, very worrisome. That you have two here, you have two high risk. So that patient, strongly consider surgery. What I usually do, if you have this and it's found on a CT scan or an MRI, usually I'll send the patient to have an endoscopic ultrasound. Remember, I told you, to me, that's the best test. You really get a much better picture of the pancreas. So anything abnormal here, I send for an endoscopic ultrasound and I confirm that. And if it's true, surgery, if the patient can tolerate it. So those are the high risk stigmata. Now let's go over the intermediate risk stigmata, okay, or the intermediate risk factors. The first one would be size. Anything greater than 3 centimeters is considered intermediate risk or higher risk. We've noticed, and I've actually had a few patients that have had 3, 4, 5 centimeter cysts, and when they come back after surgery, they were all low-grade dysplasia. So I said, based on size, I really didn't help me in this patient, because chances are I sent them for surgery for no reason. But again, remember, we don't know that. We know that now because we have tissue. But before that, all we had was an imaging test showing a large cyst. So, but again, the bigger the cyst, the more worrisome we tend to be. It just makes sense. If you have thick or enhancing cyst walls, so when you look at the cyst and you have the CT scan or the MRI with contrast, and you look around the cyst and the wall is lighting up, that's an intermediate risk, okay? It's just something to keep in mind. The main pancreatic duct, remember I told you high risk is greater than 10 millimeters. Well, within 5 and 9 millimeters, that's intermediate risk. The main pancreatic duct is a big deal. I mean, if you see beating of the main pancreatic duct, dilation of the main pancreatic duct, it's not good, okay? That's something. So whenever you have your imaging test, one of the main things you want to look at is the size of your main pancreatic duct. Always remember that. So greater than 10 or greater, high risk, 5 to 9 millimeters, intermediate risk. The other thing is an abrupt change in the caliber, or an abrupt cutoff in the caliber of your main pancreatic duct. So if you see that your pancreatic duct all of a sudden tapers off, it's dilated and it tapers off, it's also an intermediate risk. Always looking at your main pancreatic duct. And if anything here is abnormal, what I usually recommend is go for an endoscopic ultrasound. Very important. All right, so a lot of information. As a quick little recap, remember, we learn by repetition. Main pancreatic duct, usually endoscopic ultrasound, surgery. Mixed type, surgery, most likely. Again, I usually recommend before surgery, make sure you get that endoscopic ultrasound if you can, because that gives you a lot of information. If you have a branch duct, much more difficult. I usually look for high risk stigmata, intermediate risk stigmata. You kind of put everything together. Is it worth going to surgery? Is the patient a good candidate for surgery? That's where you have to have a lot of discussion with your team, your surgeon, your gastroenterologist, maybe if you're seeing an oncologist, and kind of decide what's the best or the next step in your case. All right, now we're going to go over, I wanted just to take a minute on tumor markers, especially your CEA, known as your carcinoembryonic antigen, and your CA19-9. These are blood tests. Now, I'm not talking about the prior CEA, which we were doing in the biopsy or the aspirate of your pancreatic cyst. This is a CEA in the blood, so a simple blood test. It's a cheap, quick blood test, or your CA19-9, also a blood test. These are not specific. Okay, let me repeat this. These tests are not specific to anything. Let's talk about the CEA first. So I've seen patients with cancer with a high CEA. I've seen patients without cancer with a high CEA. I've seen people with cancer with a normal CEA. So these things are very non-specific. Now, if your CEA is high, it just, it makes us think that maybe you might have an underlying cancer. Now, you can see a CEA, you can have an elevated CEA anywhere in the body where you can have an adenocarcinoma, for example, colon cancer, different types of lung cancer, breast cancer, gastric cancer, esophageal cancer, pancreas cancer. Cancer in multiple places can give you an elevated CEA. The second thing is smoking can elevate your CEA. Usually not very high, but 5, 6, even 7. So just note that, think about that. Cigarette smoke increases a tumor marker in your body. That's more than enough reason for me to quit, but that's another talk. But just know that CEA is not a very specific test. It kind of helps guide us. And also another way that I use CEA in cancer patients is, for example, I know let's say they have a baseline CEA of 20, for example, and I start them on treatment and the CEA starts to come down. It usually tells me that their cancer is improving. But I also want to tell you that I have patients with an elevated CEA that I have scanned them from head to toe. They've had their mammograms, endoscopy, colonoscopy, and I don't find the reason. And 5, 10 years have gone by and their CEAs are elevated, and I have not found cancer yet. So just goes to show you, it's not a very good test, but it's a cheap test. It's an easy test, so I do use it. CA19-9 is another blood test, not very expensive. It's a little more expensive than your CA, but not by much. It's, again, very easy to do, simple blood, and it's usually elevated whenever you have an issue or an illness in the pancreas or the biliary tree. So for example, if you have inflammation or an infection of the gallbladder, of your biliary tract, if you have a pancreatitis, if you have pancreatic cancer, any one of these can elevate your CA19-9. Once again, not specific. It does not confirm anything. I use it as a guide to treatment. Again, if they have, let's say, pancreatic cancer or gallbladder cancer, and the CA19-9 is high, and I start them on treatment, and I notice that the CA19-9 starts to come down, it usually means that the cancer is shrinking. So I also use these two tests, CEA and CA19-9, because if elevated, and I know you have a pancreatic cyst, then I may perform other imaging tests. For example, an MRI, an MRCP, a CT with contrast, or go directly to an endoscopic ultrasound. So I get a lot of questions on tumor markers, and the take-home message is they're not specific and they're not 100% for anything, but they are easy to do, so I do use them. Now, follow-up. Once you have surgery, or you have an IPMN that we're following you, just remember that this is what they call, IPMNs are what they call a field defect. If you've read up on this, if you've played Google Doctor, which I hate, by the way, because I think Google causes more confusion than helping you. But with that being said, if you're following a patient who, for example, had surgery, or they had, you have this IPMN, you might have read that an IPMN is considered a field defect. And all that means is if you have one IPMN, you're at risk for another IPMN. And there are people that I see that have quite a bit of IPMNs, from the head to the tail of the pancreas. Some people have 1 or 2 IPMNs. I'll give you some examples here because, we like to hear these examples. I have one patient right now. He's about, he's in his 60s, and he's had 2 stable IPMNs for about 11 years now. They have not grown. They've remained the same. So I think they're IPMNs. Remember, we said it's really very difficult to confirm, but they definitely look like IPMNs on imaging and endoscopic ultrasound. And that's what the GI doc and the surgeon is calling them, and they've remained the same. So even though 10 years have gone by or 11 years, I continue to follow up because this patient is at risk for developing more. And I have other patients where in 2-3 years, now they went from 1 IPMN to 5, 6, 7 IPMNs. So, it just goes to show you that we need to follow these patients. So even if you have surgery, unless you have a total pancreatectomy, if you still have pancreatic tissue, you still need to go to your doctor and get followed up because you can develop another IPMN, okay? And we already mentioned the follow-up of if you have an IPMN that you need to follow this to make sure you don't develop the high-risk features or yada, yada, yada. I'm not going to go over that again. I want to take a few minutes here, 1 or 2 minutes, to talk about genetic testing. So there are people that are born with a genetic predisposition to cancer. For example, the BRCA or the BRCA gene in breast cancer, there are mutations. They call them germline mutations, meaning they're hereditary mutations, which increase your risk for pancreatic cancer. For me, it just makes sense that if you have an IPMN, that's a risk factor for pancreas cancer. I want to make sure you also do not have a hereditary mutation that, a germline mutation, as they call it, that can increase your risk of pancreatic cancer. Because if you do, I may be a little more aggressive recommending surgery. So it's a simple test. It can be done on saliva. It can be done on blood. It's not that expensive, although a lot of insurances don't want to cover it, but something you can consider. And I usually tell some of my patients, especially the younger ones, listen, you're not going to lose anything by, at least knowing if you're at risk, an additional risk by having one of these germline or genetic mutations, okay? Now, I'm going to get to, I think, the most exciting part. I think this is the part you all are going to love because I'm going to go over just examples and things that I would do. Remember I told you that I was going to give you as a bonus what I would do as a cancer doctor, what I would do if I had an IPMN. And I'll tell you what, I'm going to share a little information here. I actually don't have to think much. It's quite easy for me because I have an IPMN. That's right. I was diagnosed with one a while back. I kind of know what you all are going through. I can tell you this thing kind of turned my life upside down. I mean, imagine, I'm a cancer doctor. I've spent my whole life studying. I see these patients. I treat pancreas cancer patients. I treat all cancer patients from leukemia, lymphomas to lung and breast cancer. And all of a sudden, I went in for a kidney stone, and lo and behold, yep, I had a few little kidney stones, but I was given the little surprise you all were as well. I was found to have a little IPMN there, and it's not that little. It's greater than 1 centimeter. And I can tell you that I went through all the emotions most of you have gone through. I've gone through the anger, the despair. I look at my family. I have young children. It's, I can honestly tell you this thing, especially for the first year, for the first 6-7 months was the hardest. Then, I started to repeat to myself a phrase that a cancer patient told me one time, and it's really helped me out. So I hope that it helps you out. And that phrase or the little saying was that tomorrow is not promised to anybody. Live your life to the fullest. And I can tell you that every time I start to go down that little downward slope or spiral, I remind myself, that's right, tomorrow is not promised to anybody. So, believe me, you're not alone. I'm almost 50. I'm not 50 yet, and I'm already dealing with this. So, I've seen patients that are even younger than 40. So, this is something that can affect anybody at any time. And, we're all part of the IPMN club. So at least, feel that, there's not that many of us, but there's actually more than you think. And believe me, because I see these patients. So I like to say that there's nobody out there that knows more about an IPMN than me because I have one. With that being said, I want to just tell you what I have done in my journey. The first thing that I did was, I really wanted to confirm this diagnosis. So I had an MRCP. I chose not to have a CT scan because of the radiation. And I did not want IV contrast because I said, you know what? I'm not even 50 yet. Am I going to start exposing myself to this metal in my body that may cause other issues down the line? I'm just telling you what I did. This does not mean that this is what you need to do. Remember, I'm not your doctor. I'm just telling you what I did. Hopefully, I'm able to help you out. And this is the main reason I wanted to do this video, by the way. So even though I have done other videos and I'll continue to do other videos because I enjoy teaching and I enjoy doing this stuff. But the first thing is I tried to confirm my diagnosis. So I had an MRCP and then I had an endoscopic ultrasound just to look at the pancreas. I really wanted to get good initial pictures of what this looked like. Because number one, I wanted to know, what am I up against? I mean, how big is it? How many do I have? I wanted all this basic information. And I wanted to know later on in life, the older I get and I get more imaging studies, whatever they are, I want to have good initial images so that I can compare them to. That's what I did. I believe that that it is an IPMN. I actually have two, a small one and a larger one, and or a tiny one and a larger one. And I've decided it is a branch duct, and I've decided to monitor. Okay, so the initial recommendation in my case was to repeat an MRCP in 1 year. I actually repeated one in 6 months because I have access to MRIs and anything I want. And even if I have to pay out of pocket, I will. This is my life I'm talking about. And I don't know, I just didn't feel comfortable, especially at the beginning, getting an MRI so spaced out. I did it at 6 months and everything remained the same. So thank God for that. But, I chose not to undergo contrast for the reasons I already said. So pretty much for the first few years, I'm going to have an endoscopic, I'm going to have an MRCP done about every 6, 7, 8 months just to compare. If there's any change, I'm going to go for an endoscopic ultrasound just to look. To me, that's the gold standard test, the best test. Also, when I'm 50, I'm going to need to have my colonoscopy. So at that time, what the heck, if I'm already under, do an endoscopic ultrasound. So that's my plan. So every few years, I see so much colon cancer that every few years I'm going to get a colonoscopy done anyway. So might as well just get an upper and a lower, get the endoscopic ultrasound and get that information. So that's kind of like what I'm doing. Okay. Like I said, I also did genetic testing. I wanted to know if I had a genetic predisposition. So if I did it, that's why I'm recommending it for you as well. The other thing I had to do, which to me was probably the hardest, was to get my mind in the right place. And like I said, I spoke to family every time I saw my kids. It's not easy, as you all know. We're all going through this. I spoke to friends, I spoke to colleagues. Don't be afraid to talk about it. At the beginning, I felt, I don't want to say embarrassed, but I said, how could I have this? I'm a physician. I treat this. How could life send me? I mean, the irony, I'm treating patients with this. I treat pancreas cancer and life throws this at me. So, but then again, nothing is off limits. Any one of us can get any illness at any given time. So go figure. So you're not alone, but you really have to get your mind in the right place. And like I said, tomorrow is not promised to anybody. And I'm in a much better place now. I'm much more positive, but it takes some getting used to. And I've spoken to some younger patients and they told me that it's taken them about a year and a half to really have their mind in the right place. So just keep that in mind. It's kind of like what most people have told me. Get a good team together. Find a doctor, either a surgical oncologist, which is usually a surgical oncologist is usually the doctor that manages this. So just, a gastroenterologist, get a good endoscopist that's able to do endoscopic ultrasounds, find an imaging place that you trust, and, kind of have this team that you put all your faith in and all your trust on and ask all the questions that you may have. Another question that I get all the time, should I travel to a large center? Most people talk about these large university programs. It really all depends. There's plus and minuses to this. So the plus about being close to home is your home, the comfort, your family. If you have surgery and you're home, let's say a month later, and you get a small bowel obstruction, you're not going to go to the hospital that you had surgery in. You're going to be seen by other surgeons who don't know your case. That's the downside of having surgery in a place that's not close to your house. Because any complication, any follow-up, you got to get on a plane or you have to travel far to get there. So, you really need to keep that in mind. Now, if you're going to have a simple surgery, or not a simple, there is no such thing as a simple surgery, but if you're going to have, let's say, a distal pancreatectomy, which is much simpler than, say, a Whipple or a total pancreatectomy especially, then, there might be, if you live in a large city, I'm in Miami, for example, Miami, Florida. So, I'd feel comfortable having a distal pancreatectomy with some of the surgeons that I know here, because I know that they can do it robotically or minimally invasive, through laparoscopically or robotically. And chances are I'll be fine. I mean, I've had several patients go for distal pancreatectomy, and I haven't seen one that's had an issue. So overall, distal panc, not that big of a deal. Remember, if you have a distal pancreatectomy, your vaccines, you need to have your vaccines, especially if your spleen is taken out. I wanted to throw that in there. Now, if you require a Whipple or especially a total pancreatectomy, then maybe you want to go to a more high volume center, but just something you need to keep in mind, because there are pros and cons to each one. Lifestyle changes. All right, I'll tell you what I did. First of all, the question that I get all the time is, what can I do to shrink this thing? And the answer is, we don't know. Nothing has been proven to shrink this. Now, let me repeat that. Nothing has been proven, okay, to reduce the size or shrink or disappear these cysts. There are people out there that tell you, oh, I did this, I did that. And you know what? Maybe it did. Maybe that dysplasia went from high grade to intermediate grade to low grade to normal. Could it happen? I guess so. Maybe they had low grade dysplasia and it normalized and it became normal tissue. That's absolutely possible. Maybe it worked for them for whatever reason. But remember, maybe they did not have an IPMN to begin with. Maybe they had a pseudocyst. Maybe they had a simple cyst. Maybe they had something else and it normalized. So you always have to be a little skeptical, because what some people say worked for them might not work for you, because they might not have had an IPMN to begin with. Other things that I do. I've never smoked, so please don't smoke. It's crazy. Smoking is linked to pancreatic cancer. Don't smoke. I would barely drink anyway. I mean, I would have a glass of wine every now and then. To me, I stopped cold turkey. The reason is I would still love to have a glass of wine, but I'm a worrywart. I start thinking about these things. And remember, for me, it's cancer, cancer, cancer all day long. It's what I do for a living. So as I'm sipping and enjoying that wine, my brain is thinking, you know what? I'm killing my pancreas. I'm killing my pancreas. So you know what? To me, I just noticed that it's just not worth the headache. So I'll just drink, water or one of these carbonated waters and not really drink wine. But do I think a wine or an alcoholic beverage from time to time is really going to cause all that much harm? I really don't. But, lose weight. We know that the heavier you are, the harder your pancreas has to work. So it's just common sense. Why have your pancreas working overtime? I'm eating very healthy. I've actually lost quite a bit of weight. I'm exercising. I'm avoiding fatty foods. I'm avoiding the diet drinks. I used to drink a lot of Diet Coke, and we know that these artificial sweeteners, has it been proven to cause cancer? Not really. But again, why risk it? I'm young. I have 2 little kids. I want to look after myself. So I don't want to have, I just don't want to throw any gasoline to the possible fire that I may have in the future. And I already said that I'm exercising, I'm walking, I'm jogging, doing these types of things to just try to be as in shape as possible. But I always tell people life isn't fair. I mean, I've always been in shape. I never really drank. I never smoked. Never even tried pot, for crying out loud. And I have an IPMN at my age. So go figure. Life isn't fair. Blood work, I tend to do a CBC, which is a complete blood cell count, a CMP, which is, your liver, your kidney, your electrolytes, calcium, etc., an amylase, a lipase, a CEA, and a CA19-9. These are the blood tests that I typically do. I usually do them like every 3 to 4 months. Again, I have easy access to them. Do I think you need to do them that frequently? Probably not. Maybe once every 6 months is good enough, especially at the beginning. You really want to get a grasp as to how quickly these cysts are going to grow. That's just what I do. Just, little take home. Just letting you know what I do in my case. So again, CBC, a complete metabolic panel, an amylase, a lipase. Those are markers of pancreatitis. I just want to make sure I'm not going into pancreatitis. A CEA in the blood and a CA19-9. That's what I tend to do. So I already went over, I just wanted to go over some commonly asked questions. Can it go away? I already went over that. We really don't know. It's been described in the literature that there has been a select few patients that it has gone away, but I always, question, did they actually have an IPMN to begin with? Has anything been proven to shrink? The answer is no. I tend to drink a lot of water. I suffer from gastritis or GERD. I've noticed that drinking alkaline water, some people have said that that works for them. I drink it, not really for the IPMN, but I have noticed that it's calmed down my acid reflux. So instead of just drinking regular water, I try to drink 1 to 2 liters of water a day. And it's every time I drink water, I just drink that alkaline water. To me, they're all the same. I drink all different types. Like I said, my diets, I'm not really taking supplements. Every now and then I'll take a vitamin. There are people out there that have recommended some supplements or some vitamins. Nothing has been proven, but they'll swear up and down that that's the reason their IPMN shrank or disappeared. Who am I to say that they're not, that they're right or wrong? I'm just letting you know that nothing's been proven, and I always go back to the possibility that maybe they didn't have an IPMN, but maybe they did. So, if you think something, it might help you as long as you know that it's not causing harm, I say go for it, but always talk to your doctor before you do so. And, the question that I always get, this is one of the toughest ones to answer, is, will I die of cancer? Listen, I'm not God. No doctor can guarantee this. That's why it's all about statistics and possibilities and probability. If you have a branch duct, you have a much higher risk. If you have a main duct, you have a much higher risk than if you have a branch duct. So, talk it over with your doctor. Look at these things. If you have, a main duct or a mixed, I'd probably go to surgery or at minimum have an endoscopic ultrasound. Branch duct, much more controversial as we've gone over. So following these up is definitely an option. That's what I'm doing. And if you have any doubt, go for that endoscopic ultrasound. It's a very good test. Find a good endoscopist and take it from there. So this brings us to a conclusion. If you found this video helpful, consider subscribing. I have a few videos. I'm going to make other videos as well that I believe, my goal here. I have fun doing this, and I really enjoy questions when I'm asked. Like I said, I practice. I see patients every day. So if I don't get to your question quickly, give me some time because I'm always doing something. But again, I enjoy what I do. And again, I'm part of, in this particular video with IPMN, this is near and dear to my heart. So, consider asking a question if you have one, and I'm here for you, okay? So thank you very much for your attention. I wish you all the best. Stay positive. Remember, a lot of patients die with an IPMN and not because of an IPMN. And always remember that. I tell patients all the time because I mean it. All the best to you. Bye.